Hey, good morning, everyone, and welcome to EuroNurse. If you're watching us live, great. Glad to have you on the show. Remember, you can always send your questions through the comment box anytime during the show, any questions you might have for us. If this is your first time watching our show, be sure to check out our website at euronurse.com where you can find out more information about the show. Also, the best place to go to watch all of our past episodes, and boy, oh boy, do we got a bunch of them. Want to listen to us in your car? Hey, no problem. Just go to our EuroNurse Plus area and get our audio podcast at any of your favorite podcasting platforms and listen in your car. If you're not getting our newsletter, go ahead to our website and sign up. We use MailChimp, so your email is nice and safe. You don't get any emails from other people. And every Monday, there's a newsletter that comes out just for you. Also, like to welcome a new sponsor to the show. HR Healthcare has just joined us, and they're going to be having a presentation shortly. This week, we're welcoming Noelle Vievering, who's going to be talking about dual treatments for bladder cancer, gemcitabine and Docetaxel. Really looking forward to that talk. And let's go ahead and bring in our experts right now. Experts, welcome to the show. I got it. All right. Welcome, everybody. So I'll just kick off with my introduction. My name is Vic Sinise. I am the host and the producer of the show. Always glad to be here and paying it forward with new information and new shows every week. No exciting news shows to talk about today, so I'm just going to bring it over to John. John, go ahead and give us your introduction.
Good morning. I am passionate about helping urology practices succeed so they can reach maximum clinical and financial success. And to that end, I created the Thriving Urology Practice Facebook group where we crowdsource practice management solutions for everyone's benefit. I frequently speak on the topics of coding, billing, revenue cycle management, marketing, and how to run your practices more efficiently in the era of declining reimbursement and rising practice overhead. I am John Lynn, a private practice urologist in Gilbert, Arizona, and I look forward to our discussion today.
All right, welcome, John. Lori, go ahead. You're muted, Lori.
Oh boy. Hi.
Rookie
Good
mistake.
morning, everyone. My name is Lori Atkinson. I'm a certified urology registered nurse. I have been in urology for 25 years now. And I work for a large practice, urology practice in Geneva and Winfield, Illinois. And I am here to share any knowledge I may have over these past 25 years.
All right, great. Thanks. And Noelle, go ahead and give us your introduction, and then we'll bring you in your show.
So I am Noelle Vievering. I have been a urology nurse actually only for about a year, but I've been a registered nurse for quite a bit longer than that. Work for a larger practice here in Minnesota.
All right, great. Let's go ahead and get your slides in here and take it away.
All right. So big topic here, the sequential treatment for non-muscle invasive bladder cancer, gemcitabine and docetaxel. So biggest things to understand first is just kind of what it is, how it works. So gemcitabine and docetaxel, like I said, is sequential treatment, meaning they're used one after the other. Chemotherapy medications for that bladder installation or intravesical installation. Gemcitabine is an anti-metabolite chemotherapeutic agent. It actually helps to result in cellular death of cancer cells. It does so by preventing further DNA synthesis and ultimately resulting in apoptotic cell death, which is when the cell components end up splitting into smaller sections and being divided by a different membrane that's later discarded. It also helps to allow for improved uptake of taxane agents, which is a docetaxel is a taxane agent. And it does this by kind of preparing the urothelium of the bladder. So docetaxel, again, taxane agent, it helps to inhibit cellular duplication and reproduction of those cancer cells. So it keeps it from continuing to grow. It does so by opposing normal tumulin function, resulting in the inhibition of cell mitosis by interfering with the microtubules, which are the cells within, or the contents within the cells that help to separate the chromosomes during mitosis. Um, Again, there is a synergistic effect with the docetaxel gemcitabine, where gemcitabine, that's exfoliative effects, help to improve that uptake of the docetaxel. So indications of why would your practice be using it? It is used for high risk non-muscle invasive bladder cancer. It's also used for Bacillus Calmette-Guérin failure, or BCG failure, as well as BCG naive patients. BCG naive are patients that have never received BCG before, whether it's due to them having a pre-existing um, immunosuppression of immunosuppressive disorder, or as we all know, we've all dealt with BCG shortage. If there's just not enough to be able to fully treat the patients, they have never received BCG before. It's also tends to be kind of that last ditch effort. You've used BCG, you've used gemcitabine, nothing seems to be working, to avoid that radical cystectomy, so preserving that bladder. Kind of that last ditch effort to do that for the patients. So, treatment wise, how the process goes, it is best to treat the patient, have them pre-treat themselves. So, writing a prescription for oral sodium bicarbonate, 1,300 milligrams. The patient should be taking that the evening before each treatment, as well as the morning of each treatment. Our practice, we always complete labs the day of. We are blessed to have a lab in clinic that can run all of these things for us. If you don't, probably want to maybe to have them complete some labs either a day or two before treatment. The labs that we complete are urinalysis, CBC or complete blood count, and CMP or complete metabolic panel. The reason why we are running these things is we want, for the urinalysis, want to evaluate for any UTIs, any gross hematuria. For the CBC, we're looking at platelet counts, making sure those platelet counts are 150,000 or greater, or the white blood cell counts are greater than 3,000. We're also looking for, when it comes to the CMP, looking at the kidney function, especially the creatinine, making sure that that's within that normal range of 0.6 to 1.3 milligrams per deciliter. And then we're also looking at that liver function, the ALT, AST. We look at these things because we want to make sure that the patient is healthy enough to receive the medication. It is generally accepted that with intravesical treatments, there isn't a systemic effect to the patient, but sometimes we do see trends in these, whether it's related to the treatment or something else, and we want to make sure that we don't exacerbate any symptoms that they may experience, or any other comorbid symptoms that they may experience. So after we do all of that, labs come back, we bring the patient into the room, kind of have a discussion of how their last treatment went, how long they were able to hold that docetaxel, as well as assessing for any symptoms of urinary tract infection or anything like that, or any symptoms that they experienced immediately following the treatment. If any of either the labs are off, or you're noticing a trend in the labs that are maybe headed in the wrong direction, or the patient is currently at that time experiencing any unusual symptoms, we want to go ahead and check with the physician before proceeding with any treatments. So after all of that, assuming all is well, we're a go for proceeding with administering the treatments. We will catheterize the patient and completely empty the bladder. In our practice, we actually use a Foley catheter and then plug the catheter for the first initial treatment. A lot of the research studies that I had read about this were talking about using a straight cath method. We do not do that just because then you would be catheterizing the patient twice for each treatment process. We want to reduce the risk of injury or irritation to the urethra, as well as reducing that risk of urinary tract infection. You know, every time they have catheter placed, it increases that risk. So we try to reduce that as much as possible. So bladder is all empty. We go and prepare the medication, make sure you're doing your medication rights to administrations, making sure you're checking right patient, right medication, dose, route, time, and doing your documentation afterwards. For the gemcitabine, we start with that one first, and we instill 1 gram per 50 milliliters in normal saline. And we have the patient hold that, or we plug the catheter for 60 to 90 minutes. 90 minutes is the ideal time, but as long as the patient can tolerate it. Once they've reached that threshold, we'll come in, completely empty the bladder. Our practice usually uses urinals for this part. Draining the bladder into the urinal, capping that off. Then we place that urinal inside of a chemo waste bag, which thus ends up in a chemo waste disposal container. So once all the bladder is completely emptied of that gemcitabine, we'll move forward with instilling that docetaxel. That is 37 milligrams per 50 milliliters of normal saline. Once that's instilled, we remove the catheter. We advise the patient not to urinate for 90 to 120 minutes. We advise the patient to roll, change positions often, especially if we know that that tumor burden is either on the dome or the lateral wall of the bladder, making sure we're hitting all of those surface areas. If the patient is experiencing any issues with nausea, they report that at, their subsequent visits. They may be prescribed danzatron for that nausea. If they're experiencing some bladder pain, discomfort, spasms, we can prescribe or advise that they use naproxen. So side effects, barriers, contraindications. So the most common side effects that a patient can experience with this treatment is urinary urgency, frequency, gross hematuria, and dysuria. Some of the other side effects are bladder pain or bladder spasms, flank pain, urinary tract infection, retention, nausea, fatigue, and rash. In our clinic, what we see a lot of as far as patients reporting any side effects is that urgency, frequency, the dysuria, bladder pain or spasms. Usually that's during the gemcitabine. As well as we do see some UTIs every once in a while, just again due to that repeated catheterization. Common barriers to implementing this into a practice, workspace. As I had mentioned, for us, we keep the patient in the clinic, in the room for the duration of the treatment. Usually takes up a room anywhere between 2 to 2.5 hours with doing the whole process. So making sure that, there is space available for that, or if there's not, how you can accommodate that. Pharmacy supply isn't a huge issue other than when you first just get up and running, making sure that you have the supply of the medications, the other supplies that you'll need to complete the treatment. Cost, always a factor. Medication costs are high. And then when you're first getting up and running, you also have some overhead costs of making sure you have all the equipment and other items that are needed for this, as well as you're looking at the cost for the patient and dealing with insurances and such. Lastly, also just, identifying those appropriate patients. So going back to the indications that we had talked about earlier, just making sure that the patient's diagnosis and treatment plan fall into one of those areas that they are appropriate for this particular treatment. Some of the contraindications, so some of the what I call hard stops for instilling this medication is symptomatic UTI, gross hematuria, and then traumatic catheterization. They're hard stops in the fact that if they are experiencing these symptoms during the day of treatment, we put a hold on treatment that day, we don't give it that day, and then we will see them the following week, let everything kind of calm down, let their body heal, and then we'll tack an extra treatment on at the end. So study data and efficacy. So all of this information I've gotten from multiple different research study sources. They all seem to be pretty well aligned. Reoccurrence-free survival. So the percentage of patients that did not experience any reoccurrence after that first initial treatment or induction course. 6 months, it's 89%, 12 months, 85% of those patients, and then 24 months, 84% of those patients were reoccurrence free. They all generally agree less than 10% of any of the patients in the studies required any modification to their treatment schedule. So that was kind of what I was talking about before. If they have gross hematuria the day of treatment or UTI, any of those things that we're looking at, having a hold on that and then having to add another treatment on at the end, those are the kind of modifications. 0% disease progression or death related to the bladder cancer. So it seems to be, it keeps everything at bay, if you will. So, and they all agree patients in each of the trials tolerated this treatment pretty well. And it was found very effective for those patients who are BCG naive for non-muscle invasive bladder cancer. And it is, as I mentioned, a little more readily available. Again, we've all struggled with the BCG shortage and trying to figure out how we're going to best serve our patients and make sure that their cancers don't progress or continue to reoccur. So this is a very, very good alternative treatment method for the BCG. So surveillance and maintenance. So what does this look like after they have done that initial induction course? It is recommended that the patients go through, have a cystoscopy with a bladder cytology every 3 months for 2 years following that initial 6-week induction course. After those 2 years, as long as the patient is reoccurrence free, there's no new signs of any bladder tumors starting to come back, then the patient will be moved to an every 6-month cystoscopy and bladder cytology. It is recommended that when the patients are having their cystoscopies, that it is the blue light cystoscopy when it's available. However, it's not always widely available. It's an expensive piece of equipment. And so if it's not available, an in-office cystoscopy will suffice. For the bladder cytologies, it is recommended to use a bladder barbotage or a bladder wash for those to be collected. And maintenance-wise, it is recommended to do monthly treatments for 2 years. So once a month for 2 years following that induction course. After the 3-month cystoscopy, the patient will come in once a month to receive a treatment. And that is all I have for you.
All right. Well, thank you. That was great. I have a lot of questions, so I'm going to kick it off
Fire away.
because I can. So now the medication is a chemotherapeutic agent.
Correct.
Do you mix this in your office? Does it come pre-mixed? What kind of container is it in?
Sure. Yeah. So they come in glass vials. The gemcitabine is partially mixed, so it comes in 1 gram, and I believe it's in a 32.6 milliliter solution. So then we have to add a little bit of that normal saline to get it to that 50 milliliters.
Mhm.
And then as far as the docetaxel, that just comes in a small vial. So we draw up our 37.5 milligrams, draw up the remainder that we would need depending on the concentration of the docetaxel. There are a few different concentrations out there to make it to that 50 milliliters. Mix those together. We mix our everything under a hood. Again, we are blessed to have an in-house lab that has a hood that we can do all of this.
Yeah, that was going to be my next question is, did you have a hood for that? Because I know that we didn't have a hood in ours. We were lucky enough to have pharmacy located right down the hallway from us, and they did our pre-mixing in their hood. So that worked out well for the drugs we gave. I never gave that particular one. Now with BCG, it comes with a little 50 cc vial and a tubing, and that's infused into the catheter. Is this similar? Is it a gravity drainage system, or are you using a Toomey syringe to push it? What are the precautions?
So it is recommended to either do by gravity or a slow push. For the docetaxel, it is a slow push over 5 minutes or by gravity.
Good. And in your experience, what's the patient tolerance been on it?
The patient's tolerance have been pretty well. We haven't experienced too many issues. I would say the hardest point that patients have relayed to us is with the gemcitabine, that initial one. It's a colder solution. It irritates the bladder a bit more. And so it's making sure that they're not having bladder spasms and those kind of things where, like I said, we use the Foley catheter, so they're not leaking around the catheter or anything like that.
And what size catheter do you normally like to use?
Um, it kind of depends on the patient. Some of them have larger urethras, but we generally use a 16 French. Depending on their prostate, we may or may not use Coude.
All right, great. So I won't hog all the questions, but those are the ones that as I'm listening, I'm like, I got to ask these. I don't want to forget. Audience, you're welcome to submit your questions in the comments area. We'll be glad to bring those up, but I'm going to turn it over to John. Any questions that you might have?
Yeah, whenever I order one of these intravesical treatments, I always think about, is it really necessary for the patients to roll around and turn and hang upside down to expose all areas of the bladder mucosa to the immunotherapy or chemotherapy? Because the first thing you do is empty the bladder, right? And then you instill the chemotherapeutic agent, 50 cc's, and then the bladder is constantly being filled by his or her urine. Isn't that automatically exposing the surfaces? So, that's something I always think about whenever I am ordering one of these tests. And I've kind of gone away from telling the patients to roll around and hang upside down.
Yeah. I've thought the same thing. And this was more of what was in the literature. I've tried to research how effective that really is. And it doesn't sound like there's a whole lot of studies out there that prove or disprove the rolling around. So I think that's where it's kind of like one of those catch-22 things until somebody decides to actually do a research study and see if there's any difference in the effectiveness of it. This is just kind of one of those standard practice deals. Maybe the patient has a stretched out bladder and so it's not fully kind of collapsed. I don't know.
I hear you. It's one of those questions that's difficult to answer, and it's not really a big issue because what it doesn't really cost anything, and it may improve effectiveness.
The way I see it, it can't hurt, right?
No harm.
Yes.
Well, in the particular case, you're putting the first one in and leaving the catheter in, I assume with like a catheter plug. So it'd be kind of hard to be doing lots of flipping around with a catheter inside you.
They don't usually, every once in a while, just because, exam chairs are not comfortable. we check on our patients regularly throughout the process, making sure that they are comfortable, maybe sometimes shifting positions a little bit to make sure we don't have any skin breakdown for that hour and a half that they're holding these. But yeah, they don't do a ton of standing up, walking around, flipping around,
I've
hanging
always
themselves
thought that
upside down.
just having somebody be active, because sometimes I know with BCG, they'll just go home and they'll sit in the chair, until their time is up and
Mhm.
do nothing. And I'm like, that's not a good idea either. Be active, move around, kind of. I think part of it is keeping their brains not focusing on it. If you're sitting in a chair,
Mhm.
all you can think about is I gotta go. I know I'm gonna have to go. We're just
I have a
keeping yourself active.
Yeah. Yeah, I have several patients that tell me that they take a nap afterwards. They'll set their alarm for like
Yeah.
an hour and 45 minutes and take a nap. And then once the alarm goes off, they get ready and go and do their business.
All right. Lori, any questions?
Yes, so we do these in our office, and yes, I agree with you, Dr. Lim. We don't have people roll around anymore. There has been no real studies to prove that even is beneficial, and people don't like it. So we don't do that. So we do the gemcitabine docetaxel in our office. I think the challenges for us is that we're in an office and we have exam tables, and you have this patient who has to sit there for an hour and a half for the gemcitabine, and then you're putting, and I think that's our biggest struggle because it's uncomfortable, they're bored, it's stiff, the room is cold, there's nothing to do. Hopefully they have a phone on them to do, that they can do something with. Our docetaxel actually comes in a bag. So it's interesting that you say to infuse it over or instill it over 5 minutes. I didn't know that part. And I guess I wonder why. Do you know why?
I never everything that I've looked at, I haven't actually figured out why. The best reason that logically I can come up with is to reduce the irritation of that initial hit of the medication. But I haven't found an actual reason why. It was something that was on the AUA website. So
Our
That's
our
yeah, not
biggest, I
sure.
think our challenge is keeping the gemcitabine in. And
Mhm.
because people spasm and we happen to have these doorbell ringers that people hold in the exam room so that if they need us, and it's constantly because they're feeling like they're going to spasm, yada yada. I did hear, and I don't know if anybody else has this experience in this, but I did hear at our last SUNA conference in Phoenix, there were a couple of different ideas, and I don't know if you've used any of them, but as far as the gemcitabine and trying to keep those spasm, I mean, they'll spasm, but somebody had mentioned that they had hooked a night bag, but put it on an IV pole, so it's above them, so that when they spasm, the medication will go up into the tube and then come right back into their bladder when they're done.
Interesting.
Yeah, and then I also heard somebody mention that they may have their patient come in for sodium bicarb to be instilled
Mhm.
into the bladder like the day before. I don't know. We haven't tried it yet, but I'm curious to see if anybody else has tried that, because that is our biggest challenge is the gemcitabine. Once we put the docetaxel in, they go home and it seems like they've been able to hold it just fine
Mhm.
because it's a small amount too. So.
Yeah, we've experienced the same thing. We do the oral sodium bicarb night before and the morning of. But yeah, we experience the same issues with that gemcitabine. Usually, that's the hardest part for the patient.
Yeah. Now,
Haven't tried
when
any of those other things though. That's interesting.
yeah, so when you guys also, I had a question about when they go home with the docetaxel.
Mhm.
Do you guys send them home? I'm assuming
Yes.
after.
Yep.
Okay, what kind of instructions do you give after the installation? As far as I know, they hold it for you said the 90 to 120 minutes.
Mhm.
As far as care with others around it, with the care of it after they urinate, how long after they urinate do they have to treat? We tell them bleach and so forth. Do you guys do the same thing?
We do recommend the bleach. However, I haven't seen anything that says that they have to do that with the chemotherapy. That's more the
Yeah.
BCG. We don't make them do all of the different things that like we would with the BCG. You know, for the BCG, it's bleach, 2 cups, 20 minutes. It has to sit before they can flush, and they have to do that for 6 hours after that first urination. There hasn't been any of those sort of uh, what's the word I'm looking for? Requirements as far as how they're doing the process at home. After the first urination, it's generally considered okay.
Yeah, we didn't see really any information when we were doing that as well. So we just decided to figure we'd use the following, the existing instructions for BCG. We just kind of have them do the same thing.
Yeah. So now I'm going to take an answer to the question as far as the installation, why it's done slowly, because I've done a lot of urodynamics. And if you crank that machine up in the beginning of the test, you'll see bladder spasms just from the infusion rate. So
Yeah,
that's
and I
why
figured that would be the case, but I haven't seen that. Like when we install the docetaxel, I haven't seen people really react that way, and we don't go over 5 minutes. We do it slowly because it's a gravity.
yeah,
but
the
not
gravity
5
feed should be
minutes.
fine. I don't know if the 5-minute part, I agree on that because it's not that much fluid.
Yeah.
Yeah.
Yeah, that was like I said, that was something that I was kind of curious about as well. But if anything, we have seen with the gemcitabine is having that issue of if it goes too fast, is having those bladder spasms. We haven't had a ton of patients that have really experienced that like almost instantaneous bladder spasm with the installation. But when we have found that if we go a lot slower, that generally helps for them to tolerate it better.
So we have a comment question from Jennifer. Great info. We're doing it very similarly at the Maples.
Minneapolis.
Oh, Minneapolis. Oh God. Okay, I'm not okay. Got it. We've been keeping our patients with the Foley through the dosey dwell time and pulling it at the end of the whole process. So I guess the question is, so you keep them there for a long time.
Yeah.
Sounds like.
I don't know that our patients would like if we kept them through the dosey portion of it
No.
as well. They're pretty sick of us.
Yeah, they're pretty thankful once they can get out of there for sure.
Yeah.
Susie wants to know what is the purpose of the sodium bicarb?
So it helps to alkalinize the urine, helps them to tolerate that a lot better. I was also doing a little bit of research as far as that as well. And it looks like it also may help with the interference of the growth of cancer cells as well, when you use that in conjunction with the treatment. Haven't done a ton of research on that though, so I'm not exactly sure how that works chemically wise, but that's what I've read.
Yeah.
All right. So Melanie, we administer gemcitabine in our office, but have not yet added docetaxel. When we administer gemcitabine, we use 2 grams per 50 milliliters. When adding docetaxel, is the gemcitabine dose reduced to 1 gram per 50? We do.
Yep, that's the protocol. That's the standard for doing the dual treatment is it's a 1 gram versus the 2 grams.
Right.
Do you ever reduce the concentration if a patient's complaining of not tolerating it well, or haven't seen that?
We have not, no.
Okay.
I think what we do when they really have those spasms, we do the best we can. And if it's a done deal, it's a done deal. We just move on.
Yeah.
I mean, there's nothing you can do about it. We do the best we can.
Hey, by the
We
way,
might
Lori,
try an oxybutynin the morning of sometimes to see if that'll help, but
that great
same.
idea about putting it on the IV pole so that when they have spasms, that's my idea.
Oh, it was yours?
I heard it.
I heard it from someone.
Yeah.
But yeah, I thought I think that was like the biggest thing I got out of the conference is, we got to try that because that's our, that's
and it works. I'd use it for BCG and it's just fantastic. You have to use a large enough catheter, like an 18 or 20, and just let it just kind of flow right back up. And then it goes down. Patients actually like watching it, going up and down.
Yeah. Well, it
Takes-
gives them
takes
some
the-
instant relief too. You know,
Yeah.
how
Mhm.
we're trying to tell them, don't try to pee, hold it, don't try, and they're like, ah,
Exactly.
but yeah, it gives them that relief. That's
As far as keeping the patients entertained, well, obviously you can try to provide some free Wi-Fi, guest Wi-Fi in your office.
Mhm.
And so I have something called mobophobia, the fear of not having access to my mobile device. Okay? Whether that is wireless access or internet access or running out of juice. So
Mhm.
I project that fear to my patients. And what I do is I actually have USB charging connections for Android and now, well, I guess everybody's USB-C now. But
Yeah.
I provide that for the patient at the bedside or in the room so they can charge their phones and entertain themselves. We also use when we do Euro cuff procedures to encourage the patients to void. We have one of those Amazon things that you can play running water to
Oh,
encourage voiding. So
We have a sink right next to them that we just slowly put the faucet on.
we have a sink in the room, but we want to be environmentally conscious. So we stop running the water and wasting water. We are in
Mhm.
Arizona, so
yeah.
we don't want to waste water, and that's why we converted to one of those sound machines or speakers that allows you to play the music or the
Sure.
sound of water flowing. So you can play music in the room, or we actually have monitors in the room, so you can play whatever you want in the room to keep the patients entertained.
Yes, yeah. So what we do is depending on the day, I was telling Vic earlier that we actually just started doing the apheresis in clinic. So we have a not quite fully hospital bed, but one of like the transfer beds from the hospital. So um, if that room is available, we don't have an apheresis patient, we'll actually put our dual treatment patients in there. And then we have a big TV so they can watch TV or what have you. Some of the patients just like to sleep. We do have some chargers and such. So if the patient is like, oh, shoot, I only have 10% left on my phone, we grab them one of those. They get magazines and all sorts of stuff to do our best to entertain them as much as possible. But it's some of them just like to hang out and chat too. So
It's interesting. It's a lot. Sometimes I feel like a lot of the older patients are a little lonely. Maybe they feel isolated. They just want to come in and talk at the office and hug the MAs and things like that.
Yeah.
And the other thing, when it comes to installation and bladder spasms, I'm always curious what would happen if I warmed up the water that I use when I perform cystoscopies. Would that initial irritation or shock of the fluid be less when I warm up the fluid to body temperature? I don't have a level 1 fluid warmer in my office, and I've always thought about how do I warm up the fluid as it's going into the bladder? Maybe that would help. I don't know. Warm it to urine temperature, I
Right.
guess.
Yeah, I
Well,
agree with you. Man,
mhm.
if they can come out with that,
Well,
some
yeah,
kind
and
of
I've
warmer,
always
that'd be awesome. I bet you it would work great.
Yeah, I've always thought that that's one of the biggest struggles or the biggest reasons why patients have a hard time tolerating that gemcitabine is just it comes out of the fridge. It's freezing cold. For this, we have to dilute it a little bit with some room temperature normal saline, but um, even then, it's still really, really cold. So that shock to the bladder is got to be intense.
Yeah.
And something that we probably never thought of is the coding aspect of delivering these medications. When the medication dose is delivered completely, make sure to use the modifier JZ when you are administering the medication to let CMS and the payers know. Because without the JZ modifier, your claim may be rejected.
Good to know.
Good piece of information.
Another thing you can try that I've worked with patients for bladder spasms, besides hanging it, is if it's just mild, teach them Kegel exercises. If they start to feel like they're gonna have to urinate, have them just squeeze, relax, not their hand, obviously, their rectum, but that squeeze, relax 3 times. And a lot of times that'll make the spasm go away. Again, another trick I learned doing urodynamics. When you do
Oh,
urodynamics,
yeah.
a lot of them,
Mhm.
you find all these things because you hate to do a study and then it gets thrown off because somebody starts leaking from a spasm. So I'd stop the infusion, have them do the relaxation, 3 squeezes, and I'd watch that curve come right down to nadir and then can proceed with the study. So I started incorporating that everywhere that I needed to calm somebody's bladder down.
Sure. We do a lot of the guiding them through some deep breathing, wiggling toes and things like that to just kind of help relax everything, and that generally usually seems to work, but yeah.
Yeah, those long dwell times, you need some kind of distraction therapy. I'm with
Mhm.
John. Give
Mhm.
me my phone or something to do. So
Has anybody considered like not keeping them in the office the whole time for the gemcitabine and letting them walk around, go somewhere, come back? I mean, is there anything that makes us want the patient there for the hour and a half other than they could spasm? I get it. But if there's somebody who tolerates it and you know that, because I know that in our
yeah,
office we have a problem with rooms. I mean, you're
I would.
taking up a room for over 2 hours, and we got a busy clinic going on. So if they can actually leave and kind of walk around and come back, I'm just wondering if anybody lets them do that.
We don't, but I feel like several of our patients, especially at the beginning, like you said, if they're tolerating it well, then that might be a potential. But for our patients, most of them are really afraid to leave. Even just with some of our regular BCG patients, they're so afraid that they're not going to be able to hold it. They'll actually ask if they can hang out in our waiting area or just hang out in the room to make sure that if something happens, they're in a safe place.
Yeah.
How many patients per week would you say you have on, or per day, I should say, because that the time thing is really an issue for
Mhm.
us too. How many do you normally do?
Um, it varies, but I would say probably anywhere between 1 to 3 a week, but it really does kind of vary depending
Mhm.
on that patient population and what's going on with them at the time.
Yeah. So I think the busier your clinic would be, it could be a big issue if you don't have a dedicated room or something like that. All right,
Yeah,
good.
we actually have 2 separate schedules. We have, like, a regular clinic schedule, and then we have our treatment schedule, so then our treatment schedule is kind of worked around all of
Yeah.
that if we have patients that need to stay.
That would be ideal. Yeah, we usually have to separate our patients. We can't. We'd love to do them back to back because, like you, Vic, we get it from the pharmacy, so it's easier for them to
Yeah.
mix it all up at once and get it to instead of one here, one there. But we just can't do it like that.
Yep. And what protective equipment do you recommend for the healthcare worker that's giving it? A little nod to our
We
OSHA folks.
we do full PPE, so mount, mask, gown, gloves, goggles,
Okay,
everything. Yeah.
good.
Making sure if there's any splashes or anything, we're all safe. And then if somebody is pregnant or breastfeeding, they should not be anywhere near these medications.
Yeah, that's another good point.
Mhm.
All right. We have any questions from the audience? Any more stuff out there, Lori?
No more questions from the audience.
This has really been great. Experts, any other questions? Because if we run out, that's fine for me. I think we had a
No,
great
no
discussion
more
on this.
questions. Appreciate it,
Yeah.
Noelle. That was great.
Yeah, thank you.
Yeah, I think this is it's just a fascinating area to look at, and these patients, as you say, they're scared. These most of the time these are patients that have had not their first tumor, that's a recurrence. They're worried about, you know, what's the future going to hold for them. Anytime you tell somebody you've had cancer, they go in for an operation, they come back, and now you're telling them, oh, it came back again. It's like, oh no, I'm never going to get rid of it. And then you've got this hope with the treatment option that may really prevent the future tumors. As you said, even if it doesn't, it can halt progression, which is the most important thing. I think John had
Mhm.
mentioned that at one of our talks. It's progressing on to removing a bladder is worse than just kind of halting it and being aggravated with the recurrent treatments for kind of these nicky neck tumors that can pop up. So it's really good to know there's other options out there besides BCG. And especially with the shortage too, because that's always been an issue. Hard to believe that there would ever
It's
be a
been years
medication
with that
shortage.
shortage. I mean, when is it gonna end? Seriously, it's been, oh my gosh, I can't. It's been way over 5 years now. It has to be
Oh
that
yeah,
I've
yeah.
there's
I've
a shortage.
actually read, yeah, I've actually read that it's supposed to continue to at least 2028.
Yeah, I
Is
Wow.
don't.
one of the most recent things that I've read.
We've
So
been very lucky that we have not run out. We get a certain allocation and things like that, and we put things on back order. I've got things on back order from months ago that so they kind of continually come in. But we do. I mean, the gemcitabine. I wanted to throw this out there. I don't know if a lot of people know this, but I know that they used to do mitomycin post TURBT, and a lot of people are
Okay.
doing gemcitabine instead. And it's for us, it's it works, but it's cost. And mitomycin is much more expensive than gemcitabine is. So, one question: does anybody ever do you guys do prior auths for gemcitabine docetaxel?
we do. I actually believe that we do prior auths for all of our treatments that we have, whether we at least check and make sure if it's required or not. And then we have on our electronic charting system, we have a little sticky note up at the top where it's noted that it's checked if it's required, if it is required, that it was approved, and the dates of when it is valid for.
Yeah. The only thing worse than cancer is getting a big bill in the
Bill.
mail that your insurance isn't covering.
Right. I don't
Mhm.
think we've had any obstacles with it. I haven't seen any denied. Let's just put it that way. But
And financial toxicity is a big issue, and payers are getting much, much worse when it comes to prior authorization requirements. So, for instance, if you got a prior auth for, say, Vic, the doctor in the clinic, so if you get a prior auth under Vic's MPI, and then say on the day of the actual installation, I was the supervising physician and the claim was billed under my MPI, some payers are saying, no, you didn't get the correct auth for the correct person administering the medication. So they would deny the claim. They're getting that picky. Also, serendipitously, I have a letter from Cigna saying that if you are using this is, I'll quote them. We will administratively deny claims submitted with an unspecified laterality diagnosis code. Why this is important for bladder cancer is that if your docs are not saying, is it anterior wall? Is it lateral wall? Is it multifocal? Is it at the dome? There are specific ICD-10 diagnoses for bladder cancer, and you need to be telling the coders, billers, and the insurance companies, the payers, the location, the exact location, or it could be multifocal. When you use unspecified, your claim will most likely be denied.
wow.
It's crazy.
We have a
Yeah.
comment from Jennifer. My understanding is the shortages of the BCG, I'm assuming, are a function of how BCG is produced. They have to forecast how many doses they will need and are often off. Well, they should know by now.
Well, the other problem is there was two companies that were making BCG. There's only one company now that's making BCG, and that's where the real
Right.
problem came.
Right.
And I've heard it's very expensive to produce. It's
Yep.
very specialized equipment that's needed for it.
And I think we all learned that, like Lori was saying, you order ahead of time, try to, guess what your order is going to be so you have it in the office. We had priority list of which patients needed to go on it the soonest, using the kind of smaller dosages, sometimes trying the 1/3 dose, et cetera, to try
we
to
were trying to do
stretch it
half
out.
doses. This was before gemcitabine docetaxel, but now our docs are kind of switching over just because of that. I mean, would you rather give a half
Yeah.
dose of BCG or give them a full treatment of gemcitabine? I mean, so
We actually kind of vary that. Every week we look at, our schedule, and if we have new BCG treatment patients coming in, it's their first induction. We send a quick message off to the doc saying, hey, are you okay if we split it? And letting them decide, because some of them are that greater risk. depending on their tumor, where it's located, all of that fun stuff. And so the docs will actually decide, absolutely no, they have to have a full or at least a half, no less than a half. And we kind of go from there. We still have a lot of BCG patients that we have. And so we try to preserve what we do have in stock as much as possible.
Yep. Well, very good. And any other comments to go through? Good.
Let's see. So Charlene says, this has been great. Thank you. Jennifer said the manufacturer of BCG, I would assume, has to batch produce at one time for the next year. Wow. That's interesting. Thanks, Jennifer.
I commentated on this back on July 2nd of 2019, discussing the BCG shortage and the BCG billing in the Thriving Urology Practice Facebook group. So if you're interested, you can watch it there.
Yeah. Yeah, it's its own talk. What type of things we do to try to stretch it out, and it's a shame that we even have to be there. I mean, I've been using BCG since it first came out, and there was never the thought that you're going to suddenly not have products available. But we all know the reality, right? So that's what we're stuck with.
Well, there was even a shortage of saline.
Yeah, I mean, lidocaine.
Lidocaine.
I mean, I couldn't believe that when lidocaine was, it's now in our office, it's locked up like as it was gold.
We ordered so many at one point because we're afraid that eventually we'd run out. Now we have all this lidocaine. Now we're worried about it expiring.
Yeah, right. That's the problem too, because then we all play the game. We're all human, right?
Right.
I don't care if we run out. Just I don't want to run out.
So. Right.
Just like hoarding the toilet paper during the pandemic.
Exactly. That's exactly what I thought of.
And some of the shortage, I'm sure, is just hoarding too. People get that. Oh, I heard this is going to be short. I better order more of that. So it's crazy.
We've actually ran into that here in Minnesota with the sterile water that we use for like the TOVs and such. We can only order so much per month. And so if we start running low towards the end of the month, we start like scrounging around and seeing what we can do to fix it or make sure that our little bit lasts us through the rest of the month, the last couple of days or what have you. So
like we're a third world country here in the US, huh?
Yeah.
Truly first world problems.
Exactly. Well, it's been a great discussion. I look forward to future discussions, but let's have a little intro on what's going to come up for next week.
Significant advancements have reshaped the landscape of prostate-specific antigen testing and prostate biopsy procedures. There's a growing recognition of the limitations of PSA testing alone, prompting the integration of additional biomarkers and imaging modalities to enhance diagnostic accuracy and inform biopsy decisions. Determining the clinical significance of prostate cancer involves assessing various factors including tumor size, grade, location, and the risk of progression. Clinically significant prostate cancer represents a subset of prostate tumors that possess the potential to cause harm or morbidity if left untreated. Moreover, the traditional transrectal ultrasound-guided biopsies have been supplemented by multi-parametric magnetic resonance imaging-guided biopsies. This integration has led to a reduction in unnecessary biopsies, while simultaneously improving the detection of clinically significant prostate cancer. Join us next week to learn more on uronurse.com.
So our very first episode on UroNurse was actually on PSA, and we're going to go back all the way back that way and look at PSA again and what's changed. You better tune in next week to find out. So everybody have a great day. Thanks, experts, for all your help, and we'll see everybody next week on UroNurse.
Bye-bye.
Thanks, everybody. Bye.